Okay, I'm going to talk about psychosocial support to staff in pediatric oncology in Cameroon. Next, please. So I have nothing to disclose. And this is the agenda we are going to follow for today. It will just flow as the talk gets along. So dedicated treatment of childhood cancer started in Cameroon in 2001, and it has continued till today. It started at 2 centers, so each center worked independently of the other, not knowing what the other center was going through. Next, please. So the pediatric oncology in Cameroon, this is where we are currently. We have 2 main childhood cancer treatment centers, and we have 2 independent satellite clinics, so they function on their own. The 2 main childhood cancer treatment centers are the Chantal Biya Mother and Child Foundation, which was founded in 2001 at the capital city, and the Cameroon Baptist Convention Health Services, where I work with many of my colleagues here. We have 1 main childhood cancer treatment center, the Mbingo Baptist Hospital. And under Mbingo, we have 3 satellite clinics. So I'm in one of the satellite clinics. Then the 2 independent satellite clinics are Mount Mary Hospital in Boya and a Protestant hospital up north. We call the place Gaobela. I always like to show the map of Cameroon for those of you who don't know. So we are the elbow of Africa, and this is Cameroon. You see the childhood cancer treatment centers before, and then the one I just called Gaobela is somewhere here. So you see that all of this side and maybe far north is not really covered. Next, please. So where did this all start? Psychosocial support. This, in May 2018, the pediatric oncology centers in Cameroon came together and formed the Cameroon Pediatric Oncology Group so that we could work together as one body and improve the care of children with cancer in our country. And with this unity, we noticed that psychosocial support is very important if we have to go forward with child cancer care. And all the centers really talked about it. Now, before that time, the World Child Cancer also did some work on African pediatric oncology nurses, and they found out that the nurses were exposed a lot to high rates of death and dying, things that, you know, give them highly emotive situations. Next, please. Pain and suffering because there was always reduced access to pain control. They also had high treatment abandonment in their centers, maybe because of the parents can't afford bills or they don't understand cancer, and difficulties for the nurses to define professional boundaries. Because as a pediatric oncology nurse, especially in a new center, you find yourself doing the work of the social worker. I mean, you do a lot. Then there's staff shortages and high workload. And so these nurses were really in high emotive situations. Next, please. So why is this psychosocial support very important? These highly emotive experiences can lead to burnout, compassion fatigue, and secondary traumatic stress. We'll notice that the nurses always struggle to cope with work demands, and nurses have personal issues because you have your own family, you have your own problems, you have illnesses and other things that can, you know, influence you personally. And these families, many of them don't understand cancer, and they often direct the anger of their child's illness at the nurses. So the nurses feel hopeless despite all their input. Sometimes they feel guilty, sometimes they feel like they are to be blamed for all of this because the families really, some families can really be angry and blame the nurses for everything. And so these experiences that the nurses go through, please continue. As we'll see, they also have financial constraints. Many families, parents, other caregivers will ask them to support them. with money so that they can buy food, so that they can buy medication. Sometimes because they cannot afford transportation, they ask for money. And this helps to worsen the emotional pressures that the nurses go through. So how can these nurses continue to go through all of these situations throughout their work life in pediatric oncology? Maybe at some point they need to run out of the units. So the World Child Cancer recognized this, and they developed this structured professional psychosocial support for pediatric oncology nurses. But as we will continue, we'll discover that other workers, of the multidisciplinary team found this psychosocial support to really be important for everybody, not only for nurses. So the path of the pediatric oncology nurse in the Cameroon Baptist Convention Health Services, and I think in Cameroon as a whole, the nurse was assigned to the oncology unit, do general nursing, and they just say, okay, we are going to begin a child cancer service. Please go to child cancer. And it goes the same with adult oncology. They just assign you to the unit just like any other nursing unit. Now you do on-the-job training and you do self-learning. So it's very difficult. You learn what you see. The patient who comes your way, okay, that's the disease you learn about. And you read as much as you're motivated to read. So this is a very challenging way, but I know that even in America, this is how pediatric oncology started. They did on-the-job training, they did personal learning. So we have no textbooks and very difficult internet access in our country before 2010. And we don't also have, we did not have pediatricians. And even now, in our whole system, I think we have 2 pediatricians who are based maybe in the city. So where our child cancer centers are, we have not had pediatricians. We don't do specialty nursing. So we don't have pediatric nurses, talk less of pediatric oncology nurses. Up till today, the schools of nursing offer little in oncology. They just mention some cancers, adult cancers, and they barely mention pediatric oncology. I just talked with some nurses today who recently graduated. They said, no, they just told us about adult cancer. And they didn't know that of cancer. So that is really not taught up till now. So it was very stressful. And I see that part of our emotional pressures came from the lack of knowledge. When we don't know what to expect, and then we meet things, it comes to us as a shock, and it stresses us more than if we had known that this is cancer. Some of the children will die. They come in late, and we'll have to go through a lot of pain and suffering. We have to accompany them in the journey toward the end of life. That will make us prepared. Because we were unprepared, we didn't have this knowledge, I think we were more or less very traumatized. So I want to think that maybe in other sub-Saharan African countries, just like us, much of the stress, or a significant amount of the stress, is because maybe we did not have all of this about what to expect in pediatric oncology. Next. Oh, okay, let me increase my volume. Sorry. Hello, can you hear me? Can somebody hear me? Okay, thank you.
Yes,
Yes.
Okay.
Much
so
better
the aim,
now. Thank you.
Okay, thank you. The aim of this psychosocial support was to train and equip nurses with skills to help them achieve a better emotional balance in their day-to-day work. Because after everything, we have to do pediatric oncology. Somebody has to be there. So the initial intervention was a training of trainers workshop, which was organized in December 2019 by the World Child Cancer. And this was led by the World Child Cancer Psychosocial Support Advisor. Can you put on the slide? So this was led by the World Child Cancer Psychosocial Support Advisor, and she trained 30 representatives from 5 pediatric oncology centers. At that time, we came together 5 centers because the other center up north was very far. So these 5 centers bring together our 2 main centers and the satellite clinics. And this at that time was made up of 4 modules. And with this initial intervention, the trainers who are trained in this initial workshop will go back to their various centers and they will train their fellow colleagues on psychosocial support to themselves and to the patients and their families that they take care of. Next, please. So next, please. So the first part of this training was made up of 4 modules. We looked at the emotional impact of childhood cancer, supporting families when a child has cancer, supporting ourselves as healthcare nurses and each other, and then building resilience. And going to the modules proper, the initial impact of childhood cancer cuts across all the stages of cancer, from diagnosis to treatment, to post-treatment, and to survivorship or bereavement. And we looked at the emotional impact on the parents and the guardians, the child, and the wider family. So everyone is affected, even those who are not in the hospital. Then we also looked at the 5 stages of grief. Grieving does not only occur when somebody dies, but when you have a difficult illness like cancer, then those 5 stages of grief come into play. And when we are aware of this, we'll be able to support the families better. And we also looked at the emotional impact on ourselves, the healthcare providers. So we were thinking that this was only nurses, but when we started the training, we noticed that everybody is involved. So all the members of the multidisciplinary team have an impact when a child comes with cancer. And we need to be aware of this so that we can take care of ourselves. Knowing all of these emotional impacts that the family and the child go through, we need to know how to support them when a child has cancer. And one of the ways of supporting the families when a child has cancer is using a range of distraction techniques. Treating a child with cancer is not like malaria, like I call it, because what is common around us here is malaria, or maybe pneumonia, where a child is admitted and you give a series of injections, and after some time the child goes back home and the child is fine. You know, we have all this follow-up. The child goes home and comes back, so many follow-up visits, and we have a series of painful procedures. And sometimes these children, or most times, they even anticipate the procedures. I had one child who used to tell the mother in the morning, please, are we going to the hospital again? Yes. Will I be pricked on my back? That is lumbar puncture. When the mother says yes, she will just shed tears. So we know this child has already registered lumbar puncture that is very painful. So we use distraction techniques. Another method that we use to support them is how to communicate effectively with children. When we learn how to communicate with them, you know, in our ordinary training, we don't do these details, but in pediatric oncology, it is so important. We are with the children all the time. We need to learn how to communicate effectively with them, not just communicate, but do it effectively, such that we create a relationship with the children and lessen their pain or their discomfort. Then another way, we employ active listening skills to these families. They always have something to tell us. And if we don't listen actively, we will not be able to hear them. Sometimes a parent comes to you and let's say somebody comes with a child with a retinoblastoma and that child is 2 years old or 3. And she tells you that I've left my baby 1 year, 2 months old at home. And if that child has to live, like we have a parent home, if that child has to live in the hospital and live in the parent home with the mother, think about that baby 1 year, 2 months old at home. So you're listening to her. When she's giving you some complaints, she wouldn't tell you that, you know, that my baby at home. But if you listen actively, you hear her give complaints that tie with the baby who is still at home. Next, please. Now, how to break bad news to children and families. It's so important. When we learn how to break bad news to the children, to the families, how to tell them they have cancer, how to tell them the intent of treatment is changing now from curative to palliative. It's going to lessen the pain they go through, and it's also going to help us to lessen our own pain. When we know what to do, we support them better, and in turn, we are supported better. Next slide, next please. And we also identify obstacles that can occur when we support families. Despite everything that we are going to do, we will not eradicate everything. There will be obstacles. We need to know about this and be prepared. The third session was on supporting ourselves and each other. So as healthcare professionals in pediatric oncology, we need to support ourselves. We need to recognize the signs of stress. so that when you see yourself getting stressed or you notice the signs of stress in your colleague, we can quickly catch it before the person breaks down. And you can cry out to your colleague, this is what I'm going through. Then we discuss the mutual support systems that we have at hand. Like at that time, what did we have that we can use to support ourselves and each other? And there were some of the things that we actually have that we didn't use because we're not aware of supporting ourselves and each other, no, the way this training brought it to us. And then we agreed on a team support plan, the psychosocial support action plan. I bolded and I put it in gold because this is like the crux of this training. When we did this training and we developed the psychosocial support action plan, it handles everything together and it helps us to support each other and to support the families and their children better. And we also looked at how to achieve a healthy work and life balance. And we used a method, sharpening the saw. If you have only one tooth of the saw working, it's going to wear out soon. But if you sharpen the others and oil everything, it can cut faster. So this is the idea behind supporting ourselves and each other. So we have to sharpen one another, but as an individual, you have to sharpen every aspect of your life so that you function better. Next, please. We also looked at developing resilience. And the first aspect of it was the characteristics of resilient people. There were 10 characteristics which we looked at, and we tried to see which ones do you have, which ones can you develop. We also measured our current levels of resilience at the time of the training, and we are encouraged to measure the levels time and again so that you see whether you're building on those characteristics you did not have. Then we looked at dealing effectively with setbacks. Despite everything we will do, there will be setbacks. When there are setbacks, do we break down? No, we have to keep strong and then keep on with the work, keep on with our life. So that is what resilience is all about. And we also looked at reframing behavior to achieve a positive balance. You know, we cannot always change our feelings. We cannot always change our attitudes, but we can slow down and then change the behavior that we project to people. When you project positive behavior to your colleagues, to those families, you in return get positive behavior. But even if they projected negative behavior to you and you returned negative behavior, it gives you more emotional trauma than if you had reframed your behavior and projected something positive. So this is what resilience is all about, staying strong in the midst of adversity. This is initially what we went through, and we got sponsorship from the Sanofi S Macha Matters Award in 2020 and 2021 with the COVID, but we successfully went through with the other trainers to cascade this training to our fellow colleagues. Next, please. So the results, we have trainers, you know, other professionals who can train others in psychosocial support. And we've done these trainings in different centers, so there are people who can do this training. We also trained a number of healthcare professionals in the rollout, 160 healthcare staff, and 117 of them were nurses. You know, we initially focused on nurses, but we noticed that everybody really needed it. And we had an action plan for psychosocial support for the patients and for the staff. And in each unit, it is modified and we adapt it annually. So even though we have some themes that are common, there are some things that are center specific and they handle it at the level of that center. And the actions that we took included establishing a parents and patient support group. And then we introduced a psychosocial support assessment tool. So our chaplain and bingo is really, since we have a parents home there, the patient and parents support group. So the patients and the parents and the staff led is really going on there. So this is a summary of the training. I won't belabor, but we have all the figures. So 2 centers meshed together. We handled the trainings in 4 centers. Next, please. So I just have some photos here of the trainings. You know, these are supervisor addressing the participants at Mingo Baptist Hospital and Main Center. And then this is a session on supporting families when a child had cancer. You can see it's a male facilitating, not me. And then this is a session on building resilience. And this is another Center, Baptist Hospital Mutengene, the administrator of personnel opening the session when we started the training. And developing the psychosocial support action plan in groups. So this is the first center that worked on the psychosocial support action plan. It was challenging at the beginning, but we went through it. Next, please. And this is the first center in Cameroon, the Fondation Chantabia. So this is a session on resilience. And the next photo is showing the end of training at the Chantabia Foundation Mother and Child Hospital. Both in French and English. So, what have we achieved so far?
Sorry, please mute your microphones when not speaking. Sorry for interrupting you, Vera.
It's okay. Next, please. So we are going to look at, okay, this is my own hospital in my satellite clinic. And this is when we ran the training. Next, please. So, psychosocial support action plan. At the end of each session, a psychosocial support action plan was developed by the nurses at the end of the training session. I use the word nurses, but it was we involved everybody, so at the end it was really everybody. And various staff in the childhood cancer program have been assigned to oversee the implementation of the action plan. It's not only nurses. We have social workers, we have chaplains, we have housekeepers, that's our cleaners, we have the nutritionists who are in charge of things that concern nutrition. So everybody is involved. Next, please. So the activities are intended to help each other achieve a better emotional balance. If the work is easy for everybody, then at the end we get stronger and we keep on in the work. So when we talk about the psychosocial action plan, psychosocial support action plan, what do I think about? I think about concerns of the patients and their families. Then I think about concerns of the staff. And then I think about the 4 dimensions that we need to sharpen. So each time we talk about the action plan, are we talking about the patients and their families and balancing their soul? Are you talking about the staff and balancing their soul? And which areas do we balance? The physical aspect of the either patients and families or the staff, the psychological and emotional aspect, the spiritual and the intellectual. So this is what the psychosocial support action plan is all about. Now, in the action plan proper, we look at a concern or a problem. What is a physical concern? Which physical concern do patients have? We explore those. Which psychological and emotional concerns do they have? Which intellectual and which spiritual? Then what are the possible causes if we can identify? Then we propose interventions and activities to ameliorate these concerns. How frequent do these concerns occur? Some of them is just a one-time something, some is once a year, some is a continuous, or some are continuous. And then when do we start, when do we end? If we started, when do we end? And then there's a person to lead. What does the person require? And what is the cost? Sometimes the cost is just time. Sometimes it is money. Sometimes it is an item. Next, please. So we'll see here examples of the psychosocial support action plan. So this is how we developed it. This one is for parents and the patients. You can see the headings, the physical, the social and emotional, and it goes down. And then the causes, the interventions, person to follow, and it continues. So you can see some names to tell you who has to do what. So when you look at the action plan, okay, this is the person in charge. So we tell you, okay, this is what you're supposed to be monitoring, follow up this and make sure that it is done. And the frequency is communicated to the staff. So it makes people handle things such that everybody doesn't sit and hope that somebody will do. And at the end, nobody does. Next, please. So this, an action plan for staff. So the first part of it, we did it for the patients and their families. The next part is for staff. Next, please. So we have some new steps. After the rollout training, we spoke with the World Child Cancer Psychosocial Support Advisor. She was very kind. And she modified module 2 and 3 to make it easier. Okay, I'm going to answer your question later. A psychosocial support assessment tool was employed at our main hospital in Bingo. We do regular briefings when a child is critically ill or dies. Before, sometimes we do it by chance, but now we know that when a child comes in very sick and we have a lot of late presentations, we have ignorance and sometimes denial, abandonment of treatment, those things come. So we do those briefings or debriefing so that staff are aware. I put this in green because this is an aspect that makes us, grow. We appreciate the effort of colleagues when a child is suffering or dies instead of pity. If a child comes in very sick, with advanced disease, or the intent is changed from curative to palliative, or maybe from prolonged palliative to end of life, and we are able to offer care, we don't encourage pity. Even when somebody feels bad, you try to okay, this child had cancer anyway. Thank God the child was able to come to us. You did something to relieve the suffering of this child. Congratulations for all the work you did. Because if we don't try to look at the positive that we do, we stay on pitying the families, pitying the children in their bad disease, and we don't celebrate ourselves that we are able to relieve their suffering, we're able to intervene in their lives, then this will break us down more. So we focus on encouraging colleagues when they do something to these critically ill patients, to those who are suffering. And our palliative care nurse, when he goes out, we send messages, oh, that was good. Thank you for all the work you're doing. Thank you for connecting the families. Thank you for that dressing change. Thank you for all the education, for community interventions. So this, if we look at ourselves that we are doing something, and actually we do something, and we try to bring up this aspect, then it helps us to be more emotionally stronger than if we stay pitying the patients, feeling devastated over, feeling like we are wasting our time on these patients. We try to see that we are useful to them. Next, please. So since 2021, the pediatric oncology staff in the Cameroon Baptist Convention Health Services go on a retreat once a year. The one at our main hospital just took place last week, and we look forward to another one in a week or two for 2 satellite clinics. So we have new steps, and these new steps are the World Child Cancer Psychosocial Support Advisor has developed 2 more modules for this package. So we have social inclusion, disability and gender. We have children who have disabilities, maybe from cancer. So we need to be aware of this and know how to support them. Then end-of-life communication and compassion. If we know what to do, we know that we are doing it right, then it relieves us from a lot of emotional pressure, a lot of fear of, whether we are doing it right, whether we are even doing the right thing, whether we are even offering anything. So this has been very useful to us. Then the World Child Cancer hired a psychologist who offers virtual support to pediatric oncology nurses in sub-Saharan Africa since December 2021. I feel that maybe many countries have not done this training, so they don't understand the impact of the psychologist, but those lessons are really great, and we still encourage people to join. We also have a revision of the psychosocial support package. So in the Cameroon Baptist Convention Health Services last June, we did a revision with 6 modules. We started with 4 modules. And we also revised the action plan. There are things that we would have implemented and we have gone over, and then we look at new steps and we do the revision. It is encouraged that we should do revisions maybe yearly, or once we get done with something, then we can revise the action plan. Next, please. So what is the way forward? Like I say, continuous evaluation of the implementation of the Psychosocial Support Action Plan and its revision. Next. All staff in the pediatric oncology service need psychosocial well-being. It's so important when you know and you anticipate, you can prepare better. If we get improved emotionally and resilience keeps increasing, then childhood cancer nurses and allied professionals will be more stable psychosocially and support the patients and the families better, and even support themselves. So I'm grateful to the Cameroon Baptist Convention Health Services, where I've worked all this while, the Cameroon Pediatric Oncology Group who came together and brought this up, I'm very grateful to the World Child Cancer for the modules. The Sanofi Collective My Child Matters Foundation helped us to roll out this. And thank you very much, SIOP Global Health Nursing Psychosocial Working Group. I'm very grateful. Thank you everyone for listening.
Thank you too.
I saw one question. Okay. I said we have 2 main childhood cancer treatment centers. In these child cancer treatment centers, we have an oncologist, a pediatric oncologist, who sees the patients. And we have many other services that are able to do surgery. We don't have radiation therapy for children yet in this country, in neither of the centers. Then satellite clinics, like where I work, in the Cameroon Baptist Convention, we have 4 child cancer centers. Bingo Baptist Hospital is our main hospital. There we have the oncologist who resides there, and we have other services. We do most of surgeries there, except for surgery for retinoblastoma. All other surgeries are done at Bingo Baptist Hospital. We have a pediatric surgeon who does those surgeries and other surgeons. And critically ill children with cancer are nursed at the main hospital. Then out here, we have nurse practitioners, like I'm a nurse practitioner. We have a pediatrician who is not necessarily an oncologist. So we manage stable patients, like retinoblastoma, because we have an ophthalmologist here. Then we manage Burkitt's lymphoma, it doesn't need surgery. And sometimes if a child has Wilms tumor around here, the child gets induction at our main center. After surgery, the child can come to a satellite center if that is where the child resides, or if it is nearer to the child's home. Then we continue the chemotherapy. So that's what we mean by satellite clinic. You do some things, but not all. So you try to bring the care to the patients near their home. It is not mobile. The children are brought to the clinic, but it is nearer their home, and you cannot give comprehensive care like the main centers do. And we don't have a pediatric oncologist or an oncologist resident. We use internists, maybe a pediatrician. And then we have ophthalmology service. Like here, we have ophthalmology service, but the other 2 satellite centers don't do retinoblastoma. So we do retinoblastoma because we have an ophthalmologist, we have a pediatrician, and those things are simple. I don't know if I answered your question.
Yes, excellent. Thank you very much.
You're welcome.
Hi, Vera. Hi, everyone. Thank you so much, Dr. Vera, for a very, very interesting and very insightful session. I think this was great. And I think now we open all the audience, all the participants. If they have any questions, then we are very happy to take those questions.
Sorry, did we have more questions?
Vera, it's Megan here. Can you hear me?
Yes,
Megan.
Yes. Vera, thank you very much for the really great presentation. You mentioned about the psychologist in Ghana who provides support, remote support to healthcare professionals across sub-Saharan Africa. And I'm just aware that on this call, we may have some healthcare professionals who are not aware of that service. So I was wondering if you could say a bit more about it and the impact that you've seen it have on nurses and healthcare professionals in Cameroon, please.
Yes, the World Child Cancer was very generous to, hire a psychologist for us, and he gives us remote lessons. Please, sorry, there's a windstorm. If you can't hear me well, just let me know. So we have underutilized his services. He gives us very simple lessons, very simple presentations on daily life things that can, encourage us, especially working in pediatric oncology service. So I just wish to say that it has been very helpful to us, and many members of my team try to attend the sessions, except when there is network difficulty. Our main center in Bingo sometimes gets difficulty with internet connections. I think that's the only great reason why many of them do not attend. Otherwise, if the internet connections were good, they will attend most of the time. And I want to speak in their behalf, my colleagues, please. I think it's very helpful. And I lead the coordinator of our program, Dr. Francine. She's not a nurse, she's an oncologist, she's there. She attends some of the sessions when she has time, because psychosocial support is important to everybody, especially working in oncology, being somebody, you have a family, living around with colleagues, seeing the things that go on around. I think that emotional support is so important to us. I will encourage people who are not yet part of it to join, because it doesn't take long and it's really very useful. I don't know how to say it better, but it's really something very important and we really benefit from it. So if anyone wants to join, let me know. I think, I
think Megan
should I write my email address?
I think Megan has already shared her email ID.
Oh, yes.
On which
please just write Megan.
Yeah. So those who are interested in joining this training program, maybe they can contact Megan, and then Megan can add them to the WhatsApp group.
And then you can also tell your colleagues who are not privileged to be here today.
Yes, I was actually going to ask this. I have a lot of nurses in my department who will be really interested in participating in such training sessions. So if there is a way that I can make them attend this training program or be part of this program, that will be really helpful to them.
Please, I would love to share the presentation materials. How do we do it? Can you write me on the WhatsApp group? Or you send me, I can send it on the WhatsApp group, I don't mind. Please kindly remind me on the WhatsApp group so that I know where to send it and be sure that you have it. Maybe send me a personal WhatsApp text and I can send the presentation to you.
Francine maybe has a question to ask. Francine?
Okay, thank you. I don't have a question to ask, but what I want to say here is that I don't know if they have only to do it for nurses in low medium income countries, or they should do for the multidisciplinary meeting, those who really want to do that psychosocial maybe follow up, or I don't know, workshop. It's really important, because in low middle income countries, the burden that we have when we are working with children with cancer, we don't have a psychologist with us, a social worker that is even assigned with us. Usually she has so much, she's maybe with HIV program, she has so much that we see her only when we have something that is urgent. We don't usually see her. So everything is on the clinical people, the nurses. I've seen nurses organizing even burial. I remember that we were having a child. The child was coming from Chad or Central Africa. So they could not carry the corpse there. So the nurses have to organize how to contact the family. The nurses have to organize what are we going on site, what is possible to do. And the same thing even goes for the doctors, for the other member of the team, the nutritionists. Usually we go beyond what is expected. And I'm happy because even now we have what we call maybe we go out, we have a retreat. That was not there before. So those are important things that have happened. So I think that maybe this is not a concept that is really seen in low middle income countries, but if every the member of the multidisciplinary meeting can get such exposure, I think it is also going to help them. And also having maybe the feedback of other centers is going to build up the team and help them to maybe to help them to not to have burnout or depression. Thank you.
I completely agree with you. And I think coming from a lower middle income country, I know how much the burden can be when you have to deal with the patients, with the families, with the nurses, and you have so many deadlines and burdens on you. So I completely agree on that fact. And I think it will be really helpful, again, with this kind of structured training program, with such kind of orientation program for not only for the nurses, but also for those who are part of the pediatric oncology team, or in fact with those who are working in the oncology setup. This is going to be something really great. In fact, I would like to share that I, along with my co-chair Nicole, this morning were discussing on the same lines, that we were actually thinking to conduct a survey to see how common is it to have a psychosocial support program, or a psychologist or a social worker employed with a hospital or with an organization. And I know there are some countries which are not able to afford a psychologist or a social worker. So how can we actually train the nurses or the other allied professional, and in fact doctors for that matter, so that they can help the children, their families, their siblings to cope better with the disease? So I think Nicole, you want to say something?
Sure. I know there have been some surveys in the past, but it's been a while, and I think there's more focused issues for us to be looking at. So this is really an open invitation. If there's anyone that is interested on collaborating on a project like this, if you want to join our WhatsApp group and let us know, or you can contact Ayushi or me individually and reach out. But we would certainly love to solicit your input and collaboration on that, or if there's other things that you're interested in collaborating on. We just want to make this group as valuable as possible, and want to create some resources and do a little examination of what exists and what could be done to enhance the psychosocial care provided to patients, families, and staff served by us all. And with that, I know we only have a little bit of time left, but what we're hoping to do is to open this up. We have quite a few people on this call, which we're very, very happy to have such great reception. So we can either go around and introduce ourselves. Maybe that's a good place to start, but certainly if there's any topics people want us to all facilitate a discussion on, we're happy to do that as well. We want to make this group as valuable as possible. So maybe we can open it up. It's a little tricky on Zoom to introduce. I'm happy to just sort of share the names that I see on my screen, and maybe people can share who they are, what country they are residing in, and perhaps what psychosocial services are available at their institution. If that sounds okay, maybe we could start with Edward Van Villa. Or perhaps Edith?
Me? Sorry. Are you talking about me? Yes. Well, I'm Edith from Argentina. I'm the president of the Natalie Dagner Flexer Foundation, but here in the group is also one psychologist of our team in Argentina. And maybe I just can tell you that we are very developed in training and some other academic actions. And I would like to, Camila, that is new here, to continue to tell you about our foundation. Camila?
Hey, yes, hello. I don't know if you hear me well.
Estás en contraluz, Camila.
Sí,
Sorry,
pero es que
secrets in Spanish.
ahí va. Okay, I am Camila. I am a psychologist from Natalie Daphne Flexer Foundation. This is my first time in this group. So I'm very happy to participate. Edith was telling you that we have a psychology area and a social services area, like which gives, which supports things that have to do with treatment, and that we are like developing our academic area in psychology, and we have like a broad attention to families and their, well, and all members of the family. I don't know if Edith wants me to tell, or what do you want us to tell us?
Yes, I need to tell you that just to have a dimension that we receive more than 1,000 families each month, that we are always into the hospitals or in front, and we are present in 12 areas in our country. So our team from Buenos Aires, like Camila, they are the managers of the whole psychosocial support in the country. And what other thing, Camila, that I am trying to say that I think, Camila, that we can introduce the thing about adolescents and young adults, where we were talking about it. I don't know if here this group is going to make some focus on this kind of patients, but it's a new issue, I think. So I don't know, as soon as you think that it's useful to talk about ASHAs, we can think about giving some presentation or something.
Thank you so much, Edith. Just two quick questions to you and Camila. Are you part of our WhatsApp group, our psychosocial well-being WhatsApp group?
Edith is already, yes, Edith is already part, and I just joined.
Oh, great, great. So we are really interested in knowing the kind of work that you are doing, and if you follow some structured program about how to go about providing psychosocial care to the patients and families. So I think we have received a very good response today with the kind of audience today. So maybe if we plan a session next time, we can have the contact numbers of you and your team members and see if we can have a presentation next time with you, wherein you can share about your work and your experience and how you're doing, how you're providing better psychosocial care to the patients and their families. What do you think about it?
Yes, I don't know, Edith, what do you think, but for me it's okay.
Yes, we can give it in a joint way, maybe, Camila.
Yes, sure.
Can share the presentation, but I think it's, I think that we will focus on presenting the things that were not already presented.
Right,
right. I don't remember the name, but it was a great presentation. But I'm afraid I only want to present something else, something new.
I agree. And I think that's a really good idea. We are really looking forward to that. So maybe we can be in touch over our WhatsApp group and see how we can plan out this presentation. Thank you so much.
Perfect, thank you.
Is there anyone else who would like to introduce them?